welcome. It is Friday, March 14th. We're starting a little early this morning, and we are moving back to a committee bill that we looked at a little bit right before our town meeting break. And we'll have Ledge Council in with us at 8:45, but we're going to start with Sheriff Foster from the Green Mountain Care Board. And he's going to tell us a little bit about what we're doing.
Good morning. For the record, my name is Owen Foster. I'm the chair of the Care Board. Thank you for making time for me today and for others to testify. I said start at a high level and level set as to where we are and why this bill is necessary in the Care Board's opinion. Our health system is at a true inflection point with immediate risk of loss of services and loss of coverage of insurance. We have two insurers in the market, in the QHP market. One of them is domiciled here and is having acute financial distress. If the insurer has an inability to pay claims or cannot remain in the QHP market in 2026, there's a very high risk that the other insurer from New York leaves the market. That was already a risk last year. It's a risk this year. It's a risk next year. Because of the losses in the QHP market, the other insurer could not take this book of business because the losses are so huge, and we would fear that they would leave. If that happens, that means 70,000 plus Vermonters cannot get health insurance as we see it. There would be no individual plans available. There would be no small group. It means your restaurants, your creamy stands, your nonprofits, your FQHCs, your small independent practices may not have an option to buy healthcare insurance for their employees. That is devastating to public health. Second, a risk of insurer insolvency really jeopardizes the sustainability of the entirety of the healthcare system. Many FQHCs and small practices have single days cash on hand. If they don't get paid for a month or 2 months or 3 months, they're not paying their employees at a time when the federal changes are leading to large swaths of people becoming unemployed. So if we have this kind of serious issue happen where an insurer cannot pay claims or cannot be in the market, it destroys the rest of the market. And that risk cannot be minimized, or it cannot even be overstated. It is a very serious event. This bill would allow the Care Board in those extraordinary circumstances to lower the prices of particular hospitals to protect from that event happening. So the metrics here are 125 days cash on hand and a positive operating margin. I will note a technicality, page 2, line 18, 81A reads the hospital has more than 125 days cash on hand. I believe that should be conjunctive and add an and after that line 18, so that the trigger would be both 125 days cash on hand and a positive operating margin. 125 days, I would not feel comfortable as the chair of the Care Board saying that you should look at doing this with anybody with a negative margin or less than 125 days cash on hand. That would create too much risk, in my opinion, to a hospital. I reviewed the fiscal year 24 actual results this morning to see, so I could testify as to which hospitals this would catch or trigger. And it would be the UVM Medical Center, the UVM Health Network, Rutland Regional Medical Center, and Mount Ascutney. UVM and Mount Ascutney are both parts of very large systems, Dartmouth and the UVM Health Network. And Rutland is an independent hospital, not in a network. I don't have the exact numbers off the top of my head, but Rutland had, I think, about 230 days cash on hand and a positive operating margin in fiscal year 24. UVM has, at the network level, I believe it's around 145 days cash on hand and had about a 2.7% operating margin in fiscal year 24. I believe Mount Ascutney also had around 200 days cash on hand and a positive operating margin in 24. The hospitals that were really, really concerned about ongoing solvency, I mean, frankly, the truth is we're concerned about all of their ongoing solvency. But the ones in a more immediate distress, that's Brattleboro, Grace, Gifford, Springfield. Who am I missing? North Country, yes. Those would not be within this parameter and don't look like they'd be within this parameter anytime soon. The other thing I'd say is this gives discretion. It's not you must do this, it's a you can do this. I had a very good, productive conversation last night with Voz about some of this. I know they're going to testify, which is great. One of the things that we discussed was, is there another way to do this? Is there a way that the state can be part of this and the state has to put up money, not just a hospital or hospitals that are in this financial position? That was one concept that was discussed. Another was, could we do like a loan or something? Because part of the issue here is Blue Cross is taking out loans at 8% annual interest to continue operations. So that's $1.5 million a year that ratepayers have to cover so Blue Cross can get those loans. That does not make sense. So one option that was discussed on that is a private call, but I feel it's okay to share it, was, is there a different mechanism? I would say that would be great. If that happens, we don't have to do this, all the better. No one wants to do this, but the risks are very, very, very acute right now. The other piece of this that I think is important to recognize, it's only for one insurer that has acute. So you wouldn't go and say, okay, you're reducing your prices, hospital, to every insurer that you have. You're not doing that. You'd only do it for the one that's in acute financial distress as defined by this, which is consistent with the statute on control level events that Vermont has, where there's a more rigorous involvement from the state in the insurer's operations. And I think Blue Cross and the DFR are here, but that level is 150% of RBC. Currently, Blue Cross is at 213.8.
Can you explain what RBC is?
It's a measurement of the reserves that the insurer has. So I don't have the exact timing, but maybe a year and a half ago, Blue Cross was around 375, 390. And as of today, they're at 213.8. That's with a $30 million loan at 8% interest from Michigan. The DFR level, I believe, is 590 to 745, to give you a sense. That's the recommended DFR range. So if you're down around 150, you are in an acute financial risk. And that's why the state has a involvement once you get to that level. So we're not currently at that level, but where claims were coming in last fall, Blue Cross is losing $13 million a month. I believe Blue Cross, I don't know what's public, so I'll leave it to them to testify as to how much they have now. But it's a very serious situation. I think that's all on that section, unless there's any questions.
Anyone have any questions?
If it goes through this, you're gonna have this authority ongoing.
Yes. I would personally be comfortable if there was some sort of sunsetting of this kind of authority. If we're not in an exigent circumstance, no one wants this. If we can have it sunset in 2 years or need to be taken back up, fine, from my perspective.
Would you be able to recommend a sunset to us,
Yes.
a time frame and topper?
Going forward, is the plan that we're looking at going forward, reducing the prices for Blue Cross Blue Shield only infinitum?
It would only be, the only one that would be, yes, Blue Cross would be the only one that I think should be captured by this. And it could sunset, the bill could sunset, in which case you're not doing this in the future. In terms of like, when does the rate reduction stop? Two things. One, you couldn't do the rate reduction if it would mean that the hospital's projected days cash on hand would fall below 125. So you couldn't come in and say, we're slashing your rates 25%, if that meant they'd get below that threshold. And 125, you could argue is the right number is 130. You could argue the right number is 100, 135. This level is, you can move it up a little bit or down a little bit. If you move it to 160, you're not going to have UVM captured by this. If you move it to 100, you might have others that you don't want to capture because they don't have the financial wherewithal. I think UVM and it's as a consolidated obligated group We may have around 1.2, $1.3 billion. And so some of this is honestly just, we're in such a dire straits. What do we do? Where is there money to prop this up before things really get out of hand? And Blue Cross.
Well, I see it, it's out of hand now. There's a big problem.
Yes.
And what I'm concerned about is that problem going forward. It's this lowering of the rate based on whatever research you've done. Is this going to stop that from going forward?
There's no silver bullets in this. It will, right now, honestly, my opinion is we need to buy time and fix the system. And we can't have something like a catastrophic event at an insurer right now.
Yeah, right.
So no, this will not fix Vermont's healthcare problems, but it will ensure, or should ensure, it will really help get us time where we have more time to fix the system because we haven't lost the insurer. So it can get us to 2026, hopefully, and hopefully we don't have to do this, is a short answer. Now, if the rate reduction is problematic and things change in a really bad way federally for a hospital, they can come back in and say, look, what you've done is causing us a serious acute financial risk. Hospitals come in mid-year and ask for more money fairly regularly. Last year, we gave Copley, I think, a 7 or 8% increase mid-year. So we went to Blue Cross, well, not just Blue Cross, all insurers. We said, they've got a real financial problem. I know we gave them 8% in the fall. We're giving them another 7 right now. So that process can always happen. So if this is done and then somebody's going to go out of business and it can't happen, we can adjust back up. It's not like immediate, but it's pretty quick. And then you have the annual rate review process where hospitals come in. So there are things that can also protect against that. And hopefully, even by having this, things will happen and we don't need to do it. I think the hospitals would prefer that. I think Blue Cross would probably prefer that. That would be better. I thought about this morning, and I come from a large family, all of our family. Vermont right now is like one big, gigantic, dysfunctional family that used to be wealthy and now is not. And we have real problems. We got some crazy uncles, some black sheep, some stars, and whatever. And we need to come together and protect each other. And that's what this is. I think that's all I have on that. If there's anything else.
This is a very short, I mean, this is a short-term, I would call emergent authority for what is right now in this moment a dire circumstance. And we could discuss for hours how we got to this, but regardless, we're here. Do you foresee in the medium-term future, long-term future, that there is a way that we can get to a point where we're not having to do this? I mean, my concern is, okay, we're doing this now because we have a crisis at the moment. We don't want to keep doing this.
The answer is we have no choice but to do something so that we don't have this in the future. We have no other choice. So one of the big things that is being worked on, I think it's being expedited, is how do we fix this healthcare system really quickly? The financials that came in for fiscal year 24 for hospitals, there were some really deep negative margins and there was some low day cash flow. We can't continue doing this. I said this before, but where we're at is we have really serious financial problems and there's nowhere to go for money. You can't go to Vermont businesses and people. You can't go to the insurer reserves. You can't go to the state coffers. So something is going to give, and it's either going to give in a way that's productive and beneficial for the state, that's planned and intentional, or it's going to give like it's been giving across the country, which was the immediate closures. That's been happening. There's a hospital in Maine that closed just the other day. Closures in rural hospitals across the country are happening. They've been happening for years. It's actually very fortunate it hasn't happened here, but it's going to happen here. And we want to make sure that that does not. That's the whole point of the Oliver Wyman report and all the investment and all the work that AHS and the hospitals and the care board are doing right now to avoid that.
Would you anticipate that if the major insurer in the state and the other commercial insurer in the state were to leave, that our 14 hospitals would be able to continue?
Absolutely do not see that being a possibility. No.
If we do not do this, the whole system fails.
If the insurer, if MVP leaves Vermont and if Blue Cross were to be insolvent, I do believe the whole system would fail. I'm happy to be wrong.
Any other questions for Chair Foster? I anticipated. I'm going to the next section. I'm sorry, next section. Oh, next section. Sorry, I was.
The only other thing I would say, and I spoke with the University of Vermont this morning, and frankly, like many days a week right now, we are working on resolving some issues, some budget overages. I went to UVM maybe 3-4 months ago and said, we need to get on a better path. Let's do this in a productive way. We have had very good faith discussions. We're very, very close to resolving a number of big issues that would be beneficial for the state. And I would say if we're able to get there, it could minimize the need for this to be effectuated.
Section 2.
Section 1 and Section 2, actually.
Yeah.
So Section 1, some of the terms that I'm not at liberty to discuss in detail publicly at this point would make Section 1's actualization less likely. UVM is very optimistic and hopeful we get there, and so are we, but it's not done. We're working very, very hard to get it done, but we're not sure if it will be. And then we have a whole public board process, and good luck predicting those sometimes. Okay. Section 2?
Yeah.
So Section 2 relates to having an observer step in and work with hospitals and the board. The board operates very high level and regulates. We don't get into a whole lot of nooks and crannies with what's being going on at a hospital. We have found in a number of public opinions in the last couple of years concerns about credibility of some representations made to the board. They're in our opinions. I don't want to rehash them here, but there have been concerns flagged that some of the information is not, the board members have concern that it's not where we'd like it to be in terms of bearing it. And we believe that that has led to some decisions that have caused high rate increases. If you don't have really good information in what's given to us, it leads to us making decisions that are harmful for the state. We have to have information that we really understand to be true. And I'm not accusing anyone of doing anything improper. That's not what I'm saying. It is normal. There is risk in any of these numbers we see. There is difficulty in projecting anything we see. But it's natural to try and do that in a way to take risk out of your budgets. And that can lead to everyone else having all the risk. As in, if the number is too high on expenses and you say your expenses are too high or your Medicare reimbursements are too low, the way the budgets work is that leads to a higher commercial rate because they backfill the budget and the financial need from commercial. So if you say our expenses are going to be 10% higher to give yourself a little buffer in case things happen out there in the year, I understand that. But what happens is that comes in commercial out. They ask for the money on commercial. If we credit that information and we believe it's fair and objective, we do give higher commercial rates. Or if we believe the Medicare reimbursements are going to be lower, same thing. That leads us to giving higher commercial rates. And that means the risks of what goes on in the world is being borne by the commercial insured market. And then if the risks don't happen, well, commercial insured also already paid. And in this time, that's something that we can't really have. When our budgets are, they're really important for predictability for the whole state, for how much money is going to go to the hospitals, because they're such a big part of our finances in healthcare. So the insurer looks at them. And if people are going way over the budgets, it really hurts the insurer solvency. So one of the things we're trying to work through with UVM are their very large budget overages, $80 million in 23, $53 million in 24. What happens? A lot of that gets borne by the insurer, Medicare and Medicaid too, but that creates like a whole world of lack of predictability for the rest of the healthcare system. So we view this provision as helpful to prevent that from happening so that we don't have this lack of predictability for the rest of the healthcare market. So this has a provision that says in a situation where the board makes a finding of misrepresentation, we can have somebody come in and work with people to make sure that's not happening. Whether it's intentional or unintentional, it doesn't really matter. It's just that if there's a misrepresentation, we need to make sure that we all have the right information. I will throw out for the committee, Dale has a receivership statute where you can actually put somebody in receivership. That is not what I believe is intended here or what is written here. This is not to usurp board authority. It's not to usurp management authority. It's to have somebody in place to provide information and double check and take a look and act as that in between to make sure everything is accurate. Not to say you can't submit this budget, you need to ask for this. It's just to help make sure that process works better. So the trigger would be a finding of misrepresentation. You could do two additional triggers that I'll just throw out there. One would be material budget noncompliance, because that throws out the whole market into disarray, or risk of insolvency to the hospital. Now, I don't want to overcomplicate it at this moment, but those are things that people could talk about later and if this passes your committee. When Springfield went into bankruptcy, there was not great state awareness that was about to happen. I wasn't here, but my information is that we found out after I see Mike Fisher nodding his head, the state didn't know, and all of a sudden they're bankrupt. That is a very, very, very bad thing for the state to have happen. So if there's risk of insolvency in the market, it might be good to have somebody helping and working and available. So I'm suggesting that could be something the committee could consider. Again, the budget noncompliance, we are seeing more hospital budgets out of compliance every year. And they're big numbers. And that does cause that lack of predictability in the market. So those could be two other triggers. I think that's all I had on that provision.
Any questions before we move to Ledge Council? Mari?
Maybe on it, now that Ledge Council's in the room, you could repeat the conjunctive.
Oh, yeah, I've got it.
Okay.
But I need clarification, so it would be great to repeat it.
Oh,
As Carby pointed out, page 2, line 18, C1A reads, quote, "The hospital has more than 125 days cash on hand." I think it should be conjunctive with an "and" after cash on hand. So it would be both 125 days and a positive operating margin.
Jen Kirby, Legislative Council. That's fine conceptually. It's not, I need to restructure it in a different way to just make it an A that is both things together and then a B that is what is now C.
Yeah.
So that's what I need to clarify.
I think
That's
it's,
why I wanted to understand the intent.
all right. Thank you.
Thanks.
And Jen, if you're able to join us
Yeah.
as soon as you. Reminder to the committee on the floor and third.
Morning, Jen Kirby from the Office of Legislative Counsel. I will put. It sounds like you've already looked at the language or you have.
We put the language, we haven't gone through the language, just.
Okay, so we are looking at, this is reminder because it's committee bill, it doesn't have a number yet, so it is 25-0975. We're looking at draft 2.3. And I have rewritten, so I've done it mostly in markup, but I did rewrite the statement of purpose just so that it reflects what's actually in the bill. And I changed the title to be an act relating to Green Mountain Care Board authority to adjust a hospital's reimbursement rates and to appoint a hospital observer. So this is the new section 1, adds a new section in the board's chapter on reduction or reallocation of reimbursement rates and risk to help insurer solvency. So this is all new. Starts off with definitions. As used in this section, hospital has the same meaning as in the hospital budget review statute. So those are basically all the hospitals, except state-owned. And hospital network means a system comprising 2 or more affiliated hospitals and may include other healthcare professionals and facilities that derives 50% or more of its operating revenue at the consolidated network level from Vermont hospitals, and in which the affiliated hospitals deliver healthcare services in a coordinated manner using an integrated financial and governance structure. I think we have looked at that, most of that before. So if the board determines after consultation with the Commissioner of Financial Regulation that a domestic health insurer faces an acute and immediate threat to its solvency because its risk-based capital level has triggered an authorized control level event under insurance law, the board may order a reduction of the insurer's reimbursement rates to 1 or more Vermont hospitals as set forth in subsection C of the section until such time as the amount of the insurer's risk-based capital exceeds the company action level risk-based capital threshold defined in insurance law. And I will defer to DFR to talk to you about exactly what all of those mean, but there are certain triggers and certain risk-based capital levels set in statute that triggered certain events involving the department. So the board shall only order a reduction in the reimbursement rates to a hospital that meets 1 or more of the following criteria. And it sounds like we're going to change this to say the hospital has more than 125 days cash on hand and had a positive operating margin in the previous fiscal year. And I'd really say 1 or both of the following. Or the hospital is a member of a hospital network, hence our definition, that at the consolidated network level has more than 125 days cash on hand or had a positive operating margin in the previous fiscal year, or both. The board shall order a reduction in reimbursement rates to a hospital pursuant to this subsection only to the extent necessary to remediate the threat to the domestic health insurer's solvency. And in no event shall a reduction ordered by the board result in a decrease to a hospital's or hospital network's projected days cash on hand to below 125 days. That is all section 1. You want me to pause there or keep
I'm
going?
sorry, yeah, can you go back to where you said this is going to change to, and just remind me what that's going to change to?
Oh, yes. So I was asked,
I know I wasn't here.
I know,
that's fine.
just a few minutes ago, I
Yeah.
wasn't here when it came up either.
Okay,
To combine A and B so that the hospital would have to meet both of those criteria to be eligible to have its rates reduced under this section.
and then under the network one, it's just one or the other,
No, it's still, yes, one or the other or both.
or both, and the first one
Unless
is
there
it
was
has to be
intended to be a
both.
change,
And the
yes.
first one is has to be
Yes.
both. Okay, thank you.
Section
I'm
2.
sorry, I didn't ask you.
No, that's all right. Can I ask Chair Foster, did you intend to do it for both for the network as well?
I
Because that would also need to be changed.
think that for the network, or is okay,
Okay.
given her, I think that's okay in the second.
Great, thank you.
Right, section 2 modifies language in the budget review statute. So this is where we had looked at the hospital monitor language, now changed to hospital observer. But also a new provision here around the individual hospital budgets established by the board under this section shall, and instead of reflect budget performances for prior years, it would say reconcile any significant deviation in revenue during the previous fiscal year in excess of the budget established for the hospital pursuant to this section using a methodology established by the board. And then in subsection F, this is the language about adjusting the commercial rates. So, I guess slightly different, but because the board may on its own initiative adjust the commercial health insurance rate reimbursement rates payable to a hospital at any time during the hospital's fiscal year in order to ensure that the hospital operates within the budget established under this section. So make changes to help them keep within their budget. And then this is the language that Chair Foster was just speaking to. The board may, and instead of at its discretion, we would have upon finding that a hospital has made a material misrepresentation in information or documents provided to the board, appoint an independent, and then as I said, we've changed monitor to observer because there was confusion and concern over the use of the word oversee and how active or passive a role that is. And there do seem to be multiple definitions that suggest different levels of control. So we have now changed monitor to observer, and then allowing the independent observer to monitor the hospital's operations. So I think the result is the same or intended to be the same, but the wording, I think, is gives people more comfort. And then an independent, and we can look at the rest of the language that you'd looked at before, if that would be helpful, maybe it would. So the board may, upon that finding, appoint an independent observer with respect to any matter related to the board's review or enforcement under this section, if the board believes that doing so is in the public interest. At the direction of the board, the independent observer may monitor the hospital's operations, obtain information from the hospital, and report findings and recommendations to the board. The independent monitor shall have the right to receive copies of all materials related to the board's review under this section, and the hospital shall provide any information requested by the independent observer, including any information regarding the hospital's participation in a hospital network. The independent observer shall share information provided by the, so this would change from may to shall share information provided by the hospital with the board and the Office of the Healthcare Advocate in accordance with subdivision D3, which also says the advocate can't further disclose any confidential or proprietary information, but shall not otherwise disclose any confidential or proprietary information that the independent observer obtained from the hospital. And the board may order a hospital to pay for all or a portion of the costs of an independent observer appointed for the hospital pursuant to this subdivision. Finally, the act would take effect on passage.
The last sentence. Board may order the hospital to pay for all a portion of. What happens if they decide not to? Who pays for it?
I would look to the board, but I believe it would come from the board either through bill back or appropriation.
It would have to be that if the hospital was unable to pay for it. Again, this is a provision you don't want to have to use. I should have said this earlier. This also relates to what I referred to about the care board and UVM's very good faith and productive conversations and resolving some issues. This would be something you wouldn't use very often. But we do believe that the investment, whatever amount it would be, which would be hopefully very, very small, would be worthwhile, and that you have the benefit of knowing whether or not an insolvency event is coming, or the stability that knowing all the representations are reliable. And budget compliance, right? You talked about the chaos that can happen when there's lack of budget compliance with the rest of the market. So a small investment, having somebody ensure that doesn't happen is beneficial. And I think also by having it, it will, just by the mere existence of the possibility, should prevent all of this from happening.
Thank you.
Chair Foster had, just to flag for you, Chair Foster had mentioned possible sunsetting of this. So he's gonna provide us with maybe some suggestions on when a good sunset would be. So just to let you.
Okay, yeah, that's been the drafting on that is pretty straightforward. So we just need to know a date.
All right.
I'll go along with whatever the committee decides, but I think that our healthcare system is so unstable right now that I would rather there not be a sunset.
Okay. I hear you. Okay, thank you, Jen. Thank you so much. Emily? Yeah. Oh, I'm sorry. The healthcare advocate,
Whichever you want.
Thank you. Good morning. Mike Fisher, healthcare advocate. Thanks for allowing me to come sit in the seat for a minute and talk about this extraordinary time we're in. I want to start by, first off, the Healthcare Advocates Office supports the committee bill that's in front of you. I want to start with a recognition that in regular times, you got a little taste of this in the discussion about the Healthcare Advocate bill with regard to our ability to ask questions of the insurer. In regular times, to use Chair Foster's metaphor, we have a good old fashioned family fight with the insurers every year. In regular times, we are putting the insurers' rate review requests through, our own actuary. We're challenging their assumptions. We're finding places where we think they're unreasonable and attempting to reduce their asks. This past year was not a regular time. This past year, we saw the significant challenges coming at us in insurer solvency last July. And so we were stuck a little bit with Vermonters can't afford this. That argument doesn't change. We still think Vermonters can't afford this. And also a recognition of, wow, if the insurers don't get substantially what they're asking for, we have a bigger storm, bigger challenge on our hands. So I want to recognize that because I think at this moment you may hear the healthcare advocate. This world tends to be divided into people who are pro-provider and people who are pro-payer. And in regular times, I think our stance is to be pretty darn critical of all actors here. But what's going on in front of us is just too hard to ignore. I want to read, there's a line that DFR uses every year in their in their solvency opinion that has always infuriated me, but looks a little bit different from today's perspective. They say, this is from last year's Blue Cross large and small group. They say DFR considers insurers' solvency to be the most fundamental aspect of consumer protection. Now, the reason that's always infuriated me is because I'm thinking in regular times, wow, a perfectly solvent plan that nobody can afford does nobody any consumer protection. So that's, again, sort of a reflection of what things look like when an insurer has, an RBC of 500 or something. But from today's perspective, that consumer solvency concern for consumers is, in our opinion, real. I think Chair Foster said it really well about just what this would do to the whole system. I still hear people say, maybe we should just let it fail. And I go, wow, that's a lot of Vermonters really harmed. One more point to make sort of on a high level is that we've been watching this unfold for a long time over at the Healthcare Advocate's Office. I have conversations with healthcare policy folks over and over and over again, and everyone sort of ends with this, what are we going to do about it? Who's going to, what is the plan here? While this piece doesn't represent a whole plan, it does represent a tool that I think is valuable. And so there's much more work that needs to be done to ensure to minimize the extent that we lose providers. I want to be clear. I think it's important that we be honest here. We're at substantial risk of losing key providers in communities that we don't want to lose. Nobody wants to lose. But the economic headwinds are real. So there's more work to be done, but we think this is an important tool. And lastly, all of this is before any shockwaves from DC. And there will be shockwaves from DC.
Any questions for? Thank you.
Thank you.
Emily?
Morning. The Deputy Commissioner at the Department of Financial Regulation. So I'm here as the regulator, the financial regulator of our one domestic health insurance company, Blue Cross Blue Shield, who offers plans in the qualified health plans in the exchange. So I think there's a few comments. I want to reiterate what previous testimony has said about how fragile our market is right now. We have two carriers offering qualified health plans right now. And if one of them does decide to leave voluntarily, or if one of them is unable to offer plans due to their solvency, we will have a market with no insurers offering coverage. There's not anyone waiting in the wings to come and offer health insurance in our state. We've asked, actually, we've had those conversations. So I want to reiterate how important this is to make sure that we maintain the two insurers we have in a way that maintains access to health insurance coverage and then also access to medical care. So going to the bill, it allows for setting reimbursement rates, as Chair Foster mentioned, in certain situations. And I will focus on the pieces that relate to the commercial insurer. In this case, we're really talking about Blue Cross Blue Shield Vermont, because they are, as I said, the only domestic health insurance company. And so the bill does reference certain controls level events that need to be triggered to enact this change in reimbursement rate. And I actually was just having a sidebar conversation with Jen to make sure that we are referencing the correct triggering event for a risk-based capital measure. So right now, Blue Cross is at 213% RBC, and risk-based capital is what RBC means. That is a measure that insurance regulators use to determine how financially solvent and how the financial strength of an insurance company. And that all relates back to their ability to pay claims. So with Blue Cross being at 213, they have a surplus right now of 58 million. That 58 million is 58 million because they took out a surplus note of 30 million with an 8% interest rate. Without that surplus note, they would have $28 million of reserves, which would put them at RBC level of below 150, which is the action level where then the insurance commissioner is obligated to take over the company. And that has never happened in my tenure at the department. I'm sure there's history there that I can't speak to. But we don't want to get to that point. That is a point where we have to start making decisions about where the risk is for that insurance company. And I can say, as the financial regulator of Blue Cross, their largest risk right now, their exposure is in the qualified health plan market. That's where they lose the most money, and that they see the most risk to their surplus right now. To illustrate that, in October of 2024, the company had a $13.6 million claims loss for that month. They had estimated, I think it was $2 million loss. So insurers usually at the end of a year, because people are fulfilling their deductibles, their out-of-pockets, they tend to use more care. So it's natural at the end of the year to see some losses on a plan, right? They usually make money at the beginning of the year, and then at the end of the year with higher claims, right? They're expecting loss. But the 13.6 million that they lost in October, and then the 18 million that they lost in December, when they had estimated $4 million losses in December, goes way beyond what a company of that size, of that scope, and with this much surplus can handle. I think we are hoping that when we see results for 2025, that we aren't experiencing these losses. But if there are, we need to have a mechanism in place to ensure that mid-year we're not in a situation where the company's RBC falls below that action level event of 150 RBC, and then the company, through the regulators, then forced to make really horrible decisions for our healthcare system. So this is a tool, as Mike said, to ensure that our market remains stable so that we can fix it versus the alternative situation where we don't have a system to fix. So I wanted to make those points. And then I also, what this bill does is it recognizes that there's a finite amount of money in the system. And when money goes to an insurance company, that money's coming from policyholders. Blue Cross takes, I think it's between 4 to 6% for their admin, their profit to operate the plan. And the rest of that is going out into the healthcare system to pay for claims and services, right? So what this bill does is it recognizes that with that finite amount of money, if one part of the system is doing better than the other, right, and we all are in this together, we all need to ensure that the system survives. It allows for some of that money to come back to the insurance company in an emergency situation to make sure that that company can continue paying the provider's claims. I think that's, oh, and one other point I did want to make is, and I think this was mentioned before, is right now hospitals through the Green Mountain Care Board have the ability to come in mid-year for a rate restructuring or to increase their rate or get an adjustment. Health insurers do not have that ability. When they contract with their policyholders or subscribers, right, they're making a year-long commitment to charge a set amount of premium for a set amount of benefits for that year. So they're taking on the risk of those policyholders. So when there is an event, like we saw at the end of last year, where the losses are way beyond what I want to mention the company predicted, and also that the board who approves the rates predicted. And when you also then have an insurance company that is in such dire financial straits, you need to have a mechanism in place to protect that entity. And again, I think this is extraordinary times. This isn't something that you want to rely on, right? We don't want to have a system where you have, there's no predictability. You want to have predictability. But I do believe that where we are right now, we need to have something like this tool in place to make sure that we can maintain our system till we fix it.
Yeah, can I ask one question here real quickly? And for the sake of time, let's be brief. I just want, you represent your Department of Financial Regulation. I'm assuming you do not have the resources to take over a insurance company.
You do not. That would be done probably by an external party, realistically.
May I ask if the administration is aware of this and if they have any concerns over this?
So the administration is aware of this bill. As far as I haven't had time to share this with my team at the department. So I'm really just speaking as the financial regulator of Blue Cross. But I do know the administration is aware of this. I have not been made aware of any concerns with this language at this point. And I think there's a recognition that we need to do something.
Thank you. Lori?
And if this was covered under Chair Foster's testimony, please say it was covered and I'll go look at that. Sorry, I was late. But I'm curious if you can give us like a 1 minute, if the insurer fails, becomes insolvent, QHP goes away.
Yes.
What does it mean to Vermonters
So,
and the hospitals?
so Chair Foster did
Okay, so
talk about that briefly, but.
don't worry about it.
Okay,
Yep, I'm good.
okay.
Thank you.
Really quickly, because I do want to get to Mr. Del Treco, and we have 10 minutes. Mari?
I think you may have covered it. I just wanted to hear more about what happens if you go into a receivership situation, DFR, then you said appoint some,
So
there's a
in many,
liquidation of assets.
in many instances, so there's two separate items or two separate triggers that can happen. One is a receivership. That's to get a company back to operating in a way that is sustainable. And then there's liquidation, right? Or insolvency, which happens when the company is too far gone to get it back to a state where they can operate. So that's when you have a company it's insolvent, it goes into liquidation. There's, a bunch of different steps that happen. Normally, insurance commissioners, there are experts who do this for a living. And so I know in like the long-term care insurance space, for instance, there's been several cases where there's a receiver that comes in and takes over the company and kind of looks from that third party view and says, okay, where are the losses coming from? What do we do to fix this? From my perspective, when I'm having my meetings with my team and I look at, okay, where can we stop the bleeding and where is there no control over it? It's the qualified health plans, it's the exchange, because that is where they take on the most risk. They do not have the ability to change their risk profile of the people who
Yeah.
purchase the coverage on the exchange, right? There's no risk, there's not a lot of risk management aside from utilization management, right? The ability to do prior auth or other tools that they have to kind of control the costs. But largely that is the area where we see the most risk, we see the greatest losses. The company has already pulled out and I think is below 10% ownership of their Medicare Advantage business now. You know, they've pulled back into all the other areas they can to try to mitigate the losses. And the last remaining place where it's really hurting the company is in the QHP market.
I'm just gonna ask you a question, but I'm not gonna ask the question. I'm gonna make a statement.
Okay,
In terms of this plan to get this company back on its feet, I am extremely worried about the individual like me buying the insurance, how much it's gonna cost me. And somewhere along the line, I'd like to get an idea of an estimate, how much it's gonna go up. And the rate payer, the person who's buying
yes,
the insurance, because I'm getting phone calls about how much they're paying now.
Yeah.
And they can't afford.
right. And I hear that. And I think, right, this is not meant to mitigate rate increases. This is not meant to solve for the affordability crisis that we're seeing. This is just to really make sure that we have a payer in our market.
Thank you.
Yeah, thank you. Appreciate it.
I may Chair, I would say that it would, affordability is one of the biggest topics we're talking about and focusing on every day for the consumer. This would actually help with that by reducing a price of a hospital service, right? There's less money coming out of the people who are paying for insurance. Yes, well, you pay less, you have to pay less for insurance.
Sorry, I apologize. I do want to, I know I gleaned it in my testimony, but I would like to suggest a change to the referencing statute of 8 VSA. I think right now it's 8305, which talks about the RBC level event. I would like to suggest a change to 8304, which I think is in line with what the committee intended, which was the 150 RBC level, which is the level I mentioned that triggers the department control of the company. So that is one suggested change I'd like to make.
Okay, thank you.
Thank you.
That makes,
That makes,
Harvey Legislative Council, that makes sense. I think that maybe we got wires crossed and directed. So
thank you. Thanks for flagging that for us. Mr. Del Checo, thank you.
Good morning, Madam Chair and committee members. First, I want to thank you for allowing me to do this over Zoom. I'm currently meeting with my colleagues from New England, and we're discussing the $880 billion federal cuts that are looming and trying to create some strategies to prevent those. So, as you know, any cut in Medicaid challenges our economy, further challenges our delivery systems, and most importantly, creates real problems for Vermonters that need care and service and support. So I know your committee's working on this every day. Appreciate that. I deeply understand the gravity of the issues and the fragile nature of our delivery system, and along with the affordability issues that we face. And I can assure you that our hospitals are working on these issues deeply, and I'm happy to go into some of that, but I know there's not a whole lot of time. But I do want to focus on a couple of things. As we enter into 2026 with the current guidance, and our goal is to adhere to that and as closely as possible, we'll be trimming close to over $100 million out of our delivery system. No simple task, and that does lead to potential further destabilization. I'll talk to the two parts of your bill right now. Under the extraordinary action part, it's very important that we understand, that I understand and some of the details here. And I want to, again, emphasize our willingness to work on the issue together. We've never encountered a situation like this in healthcare, and we've never encountered a situation where we're looking at a transfer of funds. So in the moment where we just looked at this bill last night and prepared for it this morning, I can't support these two sections, and let me go through why. So for first, the 125 days, I'm not sure where that number came from or how that works. I looked into some measures last night, and KFF defines, or Kaiser Family Foundation defines strong cash levels at 150 to 200 days for systems and 160 to 205 days for standalone hospitals. This proposal would further degrade our days cash on hand, and knowing we have this potential $300 million Medicaid reduction coming into our state would only create more uncertainty and fragility in our system.
Do you have a recommendation to change that?
Yeah, I would move it to these ranges that KFF defines.
Okay, if you could get those us.
Yeah, what is that?
He can get that to us, please.
Yep, happy to.
Okay, go ahead. I'm sorry to
So,
interrupt
and
you.
again, earlier, just to emphasize, earlier this week, the board reviewed 24 actuals, and in an odd sort of way, I was thankful that it wasn't worse, because they are real. Our financials look really, really bad. Some specifics: it's unclear how prices would be adjusted, the amount of money that's necessary, how targeted, how long would be in place. And we need these clear parameters because hospitals are required to charge everybody the same price. This action is done through contractual relationships. So how would that work? What would the money be? And how would we move through those pieces and parts? We also would need extraordinary relief from this process, where this is an extraordinary circumstance. If money was removed and a hospital decided, or a hospital is seeing their organization slide into a problematic state, how quickly could we expedite a review of the issue and make corrective action if necessary? I think we need some language that identifies a time period, 5, 10, 15 days, so we don't slide into a problem. I had a really productive conversation with Chair Foster last night, and I said, well, how can we, if we, to use the analogy that's been being tossed around, if we are a dysfunctional family and we've got to come together, how do we come together and look at not just coming out of this funding coming out of hospitals, but is there an opportunity to work with the administration to create some funding? Is there an opportunity for Blue Cross Blue Shield to get a better rate with their Michigan partner than 8% and borrow more money? And is there an opportunity for this to be a loan from hospitals paid back at some discounted rate of return as well? So how can we work together? My message here is, if we take it just from one source, we're going to create a situation where we may put hospitals into jeopardy of failing and closing. And that's really the connection I want to make. I understand the insurance side, the care delivery side, and a place for people to access care would go away. And which is more problematic, I don't know, but they both, it's pretty both darn scary. So that's that section of the bill. On the observer part, happy that the language has changed. I think we need some triggers, and we need to understand when a person enters and why they enter, and when they would leave. What would be that trigger? And then if for any reason, and I know that this is not the intent of the language, but for any reason, if this observer starts to make recommendations that are operational, there has to be some court action around that, because that does move into receivership mode more than just observer mode. So those are my comments and the reasons that for the moment we can't support this, but I do value the work of the board, the relationship with you and your committee and members, and I'm happy to answer any questions that you might have. And I've cruised through that very quickly to make sure that I don't bump into your time.
Any questions? All right, well, thank you, and thank you for the short notice joining us. We do need to get to the floor.
Yep, my pleasure.
So we'll be coming